approach to a patient with double vision. We have broken this topic into subdivision and based on the history as to how the patient will present and how do you approach those patients. May I request Dr. Ambika and Dr. Clement to join me here on dais, please. Our first speaker is Dr. Rohit Saxena. He's going to talk on approach to a patient with horizontal diplopia. Rohit is a professor at RP Center, Delhi.
Good morning, and thank you, Dr. Rashman and AIOS for giving me the opportunity to be here. I'll be talking on horizontal diplopia, and unfortunately, I do not have any conflict of interest. So the question is, we'll just start on a bit of introduction because, like, I'm going first. So whenever you have a patient who comes with diplopia, please clarify. Is it really diplopia? Sometimes, even macular issues and the patient has a little hazy vision in one eye, which is kind of overlapping with the other eye. The patient can say that it's diplopia, or, very commonly an anterior segment person will say, hey, it is diplopia and it's his job, it's not my job at all. Same early keratoconus, refractive errors uncorrected. So need to confirm that it is double vision. You cover either eye, make sure that he knows that the quality of the image is the same and it is really diplopia. So you know that now it is diplopia. The next question comes, is it monocular or binocular? Again, a lot of patients come, especially with multifocals now in one eye, or a decentered IOL, or again, uncorrected astigmatism, or early keratoconus, again, who may have a monocular diplopia, but again refer to you for diplopia because you say diplopia and it's your job now, nobody else's. So you need to confirm whether it's monocular or binocular. If it's binocular, the next question comes whether it's transient or persistent. And then once you know it's persistent, you start thinking of the various diagnoses that you're going to have, restrictive, paralytic, which could be mono or polyneuropathy, and these things we'll be discussing during the course of the day. So monocular, you cover either eye, and if it goes, you know that it is monocular diplopia, and essentially not your job, at least not as a neuro-ophthalmologist. So there are a whole lot of causes for monocular diplopia that needs to be identified by a good clinical exam of the eye. Binocular diplopia, so once you know it's binocular diplopia, it's a whole lot of various causes that are there, and that of course we'll be discussing in the various presentations. Based on the presentations, we'll be able to divide them into its various conditions. So I'll just start off with the overview. So patient has transient diplopia, worry about variability. So is it variable? Is it during the time of the day? Is it related to any? So is it related to the time of the day? Myasthenia. Is it related to getting tired in the evening or after long hours of near work? Is it a phoria that's breaking up? Is it when he's reading and he always gets it? Has he had a recent pair of glasses? So are they decentered glasses? Is the near segment causing a little bit of a tilt in the spectacles, so causing diplopia? When he's going down, is he looking through one part through his distance correction and one part through his intermediate correction in a progressive lens? So these are all very common causes, not easily picked up. So ask if he's recently got his glasses changed. Migraine, myokemia, multiple sclerosis, raised ICT. So all these are again raised ICT. Usually is going to have consistent diplopia, but sometimes it gets better as the pressure comes down. And again, when you have variable diplopia, always think and consider and worry about myasthenia. It's rare to have myasthenia without ptosis, but you can have it. This patient had horizontal as well as vertical diplopia. Again, the dictum for myasthenia is, if you do not understand the type of squint it is, think of myasthenia, because it will never follow a single pattern of a nerve involvement. So it's not like classically you can localize it's the third nerve, fourth nerve, sixth nerve. It's not multiple partial third and sixth nerve. So you have all lot of particularly both eyes getting involved. So if you don't understand, start working on myasthenia. Diplopia, ICE test is very good if you have ptosis. If you don't have ptosis, ICE test has very low sensitivity because the cooling cannot go as far back as the junction of the recti. So there it's a challenge, but you can try. Otherwise, a Tensilon test in the OT is a very, very effective one. So you know that it's persistent diplopia. You have restrictive causes and paralytic. Restrictive causes come to us fairly frequently. Thyroid is a very important problem. Usually we think of thyroid like this, prominent eyeballs, particularly elevation deficit. But remember, among the earliest problems a thyroid patient will come with is dry eye and convergence insufficiency. These are early complaints. An older patient comes with difficulty in near, blurring intermittently, see whether he has convergence insufficiency, and one of the causes of that may be the fact that he may have an early thyroid. So it's important. So near diplopia, so they may come with near occasional intermittent diplopia. Think of thyroid as one of the other possibilities. So this was a 35-year-old female with diplopia with a little bit of redness temporarily on the lateral side with swelling. Localized congestion on the lateral conjunctiva. Now, the most important thing, this patient is complaining of diplopia. The most important thing that you need to see, pointer, mil sakta hai kya? So the most important thing you need to see for is the deviation in primary gaze and the limitation of abduction that the patient has. This is showing that it's probably not a paralytic squint. So it's a recently acquired diplopia, but the deviation in primary gaze is nowhere near compared to the limitation that you are seeing here in abduction. In restrictive strabismus, this is what you will see. In paralytic strabismus, the limitation more or less is same for the, you can compare the both because the muscle is not working whether you're looking straight or you're looking in the direction of gaze. But in restrictive strabismus, the problem may occur only when you're looking in that direction. So this was a patient had localized cysticercosis of the lateral rectus. So again, you need to understand what is the clinical presentation, localize the lesion, and try doing investigation. So if you had thought this as a sixth nerve palsy, done an MRI brain without actually looking at the orbits, or they would have just missed it, you would have missed this diagnosis and thought about it. So that's the most important thing. We'll just go more detail into the paralytic strabismus. The most common purely horizontal would be a sixth nerve palsy. In the others, you're going to have vertical as well as possibly horizontal. So I'll restrict myself to purely horizontal diplopia. So this was, so in sixth nerve palsy, you have, of course, multiple causes, usually uncrossed diplopia, maximum separation of the double images in the direction of the action of the muscle. So muscle separation on the ipsilateral side. You have a whole lot of causes, most commonly ischemic in the older patients, viral sometimes in younger children. Never forget raised intracranial pressure. So any patient with diplopia, frankly, any patient, you should look at the fundus, but definitely indicated in this. MRI is indicated if there is, of course, disc edema. There are other neurological signs or symptoms in a young patient, of course. So less than 40, 45 in the absence of systemic disorders, which can give you a suspicion of a medical cause. Think of get an imaging done. There is an increase in symptoms, so you probably think it's a medical cause, it's an ischemic cause, but you follow up the patient closely, and he comes back with increase. And I have burnt my fingers thinking it's just a sixth nerve palsy, and later on we realize it's a tumor which is slowly enlarging, and the patient later developed multiple other signs, and of course non-resolving or worsening. So this was a young patient presented with sudden onset diplopia. You can see a little bit of abduction deficit on both sides, and he was complaining of diplopia on the sides. So fundus revealed significant papilledema, a raised intracranial pressure. You need to do an imaging to find out the cause. So there can be multiple causes for the same. The most important, IIH is the most commonly seen, either idiopathic or associated with venous sinus thrombosis, but often the pressures are very high by the time they are coming with abduction deficits. And the reason this happens is because of this. This is the double bend the sixth nerve is going through. So when there is raised intracranial pressure, there is a downshift to the midbrain, causing a little bit of stretch of the nerve, sixth nerve, as it goes through the subarachnoid space, and that can cause the lateral rectus underactions to present with. Again, here you see you have a patient post-traumatic coming with an abduction deficit. Why not sixth nerve palsy? The reason, as we discussed, look at the deviation in primary gaze. Look at the limitation of movement and look at the deviation in primary gaze. The diplopia is predominantly in this case. So this is probably a localized trauma to the orbit. You can see an imaging that was done. A CT is enough, then you don't need an MRI, and you can see a blowout fracture that is entrapping the medial rectus and preventing abduction. Something we've started seeing a lot more common is the diagnosis of acute comitant esotropia. Of course, we have a lot of classifications. The most important thing for you to remember, it can be associated with neurological signs, and you need to get an imaging done, particularly of the brainstem. That's the area where is the localizing. again, we keep thinking MRI tells me everything, but please remember, you need to not only give the correct investigation, you need to tell the radiologist what or where you are looking for the lesion, because I mean, they'll do a full brain. The brain scan is like, you know, going through the entire globe, and you can't identify Delhi in a, you know, quick globe scan. So same, they're doing an imaging of the MRI of the brain. They need to localize for small lesions in the midbrain where an acute comitant esotropia lesion can be. So please specify what is the area of interest. And Arnold-Chiari malformations are very, very common in young children or young adults. And of course, there can be all kinds of lesions. The one thing that is, I mean, really not classically neuro-ophthalmology, but acute comitant esotropia, children presenting out. Post-COVID, this has been fairly common. We are seeing a lot of children presenting to us with acute comitant esotropia. I still haven't changed my investigative pattern. Obviously, look at the fundus. Get an imaging done. I still get an imaging done, although pickup for imaging has really now less than 10% or probably even lower. Earlier, it was almost like 90 to 100% pre-COVID. An acute comitant esotropia would come once in 3 months or 4 months, and we have all the residents sit and discuss and get the imaging and work on that. But now, young children, lot of near work, even adults are now coming with lot of near work acute comitant esotropia. The other thing to differentiate in acute comitant esotropia is to get a cycloplegic refraction done, because accommodative spasms are the other things, but usually they'll complain of blur along with that. But if the vision is good, there is full motility and an esotropia in primary gaze. Acute comitant esotropia, like I said, I still continue to do imaging for these patients. Just to run through few of the differentials, of course, this child would not complain of diplopia, but this has, I mean, sent as bilateral sixth nerve palsy. Please remember, you need to patch one eye, just make sure that it's not a palsy. So this was just a cross fixation, very commonly seen in infantile esotropia. Just as a differential, before you start worrying of congenital bilateral sixth nerve palsy is not a common thing to see, because just the two sixth nerve nuclei are not going to develop abnormally without any other insult. So, but of course, exceptions are there. The other differential is Duan. So a young child, look for palpable fissure narrowing, look for the abduction, look for the difference, as I talked about in the beginning, in the deviation in primary gaze and the abduction deficit. So these are signs and suggestions that this is not a sixth nerve palsy. Many of these children start getting so extensively investigated that like, you know, it's unfortunate. I'll quickly just show you one more cause of diplopia. This is an internuclear ophthalmoplegia. You can see the adduction deficit, and then you do a check for convergence, and you can see the convergence is well preserved, because the convergence passes through a different route, while the internuclear ophthalmoplegia is through the medial longitudinal fasciculus. And of course, you need to again image in the midbrain region to identify an internuclear ophthalmoplegia. Just one more patient showing diplopia, left-sided. The only important thing to note is, again, I'm treading on the footsteps of speakers who are following up. So abduction deficit, mild proptosis with a slight ptosis. You identify, you localize it to the orbital apex, a Tolosa Hunt. Post-steroids is good. So early management, just follow up, prisms, botulinum toxin for sixth nerve palsy, and of course, after 6 months, maybe you can think of surgery. Thank you very much for the opportunity.
Thank you, Dr. Rohit. We're going to have questions otherwise at the end of the session, but Dr. Rohit has to go for some other talk. So if any questions for horizontal diplopia for Dr. Rohit, we'll take it now. If there are no questions, thank you.
Great. Clear
Thank
talk,
you.
huh?
Thank you, Dr. Rohit, for the wonderful talk. I think we'll move on to the next speaker. We are going on to the next two talks by Dr. Rashmin Gandhi, who needs no introduction in neuro-ophthalmology in India. He's going to talk on a patient with diplopia and ptosis and vertical diplopia.
Thank you. Thank you so much. Thank you, APO, AIOS, for this opportunity. So first is going to be a patient with diplopia and ptosis. So we have this 52-year-old male who has an acquired unilateral ptosis for the last 1 year, and this is how he looks like. He also complains that he has double vision, which is more when he's tired or in the evenings. So let's see how his oculomotility looks like. And I would like you to observe as to what's happening with the eyelids. Patient looks to the right, you see that maybe there is a limitation of abduction to the right side. You see the other eye also, other eye where there is no perceptible ptosis, you find that there is a little bit of hopping going around. You see when the patient looks down and makes an upward saccade, there is that little bit of hopping off the lid, which is called Cogan's lid twitch. And here, when you see when you lift up a ptotic eyelid, you'll find that the other eye also going down. So this is a sign of oculomyasthenia. The features which will tell you that this oculomyasthenia is where the patient was saying that there was variability, the diplopia was more in the evening or when he was tired, and those funny lid movement. I'd like to demonstrate that a little further in this video as well. So again, a 34-year-old lady complaining of diplopia, and you'll find that when we are checking an ocular motility, she's not really able to move her eyes significantly in any direction, but you'll find that lid hopping, which is very significant sign when present, suggestive of oculomyasthenia. So Cogan's lid twitch when patient looks down and then makes an upward saccades after 20 seconds, and you find that there's a lid hopping, or when you're checking ocular motility and you find that the lid is really hopping, these are signs or suggestion of that the patient might be having oculomyasthenia. The other features that you look for would be a weak orbicularis oculi tone, and when you are checking ocular motility, you will find that the ptosis is increasing. So these are the features of oculomyasthenia. One of the important tests that you can perform in the clinic would be eyes test, and you'll find here in the top picture the patient has ptosis. Patient was told that this looks like aponeurotic ptosis. Please remember, as Rohit was mentioning, any squint that you don't understand, oculomyasthenia would be a part of differential. Any acquired ptosis, you generally would keep oculomyasthenia as one of the differentials. This patient was told that maybe you are having an aponeurotic ptosis, but you see how the eyes become near normal after the eyes test. Now what happens if we miss out on the patient or the diagnosis of oculomyasthenia? This is a young man, and you see the top two pictures are pre-op pictures. He presented with an acquired ptosis, though he was told that maybe your problem is a congenital ptosis and you should undergo surgery, you'll have good results. The bottom two pictures are after surgery. So he underwent a ptosis surgery. The myasthenia signs probably were missed up in the initial clinical examination. You find in the bottom picture that now patient has a scar, ptosis is not improved at all, and now patient also has a lid lag. Another unfortunate patient who came with ptosis and diplopia, and I'm sorry for this. Again, patient was told that ptosis is congenital ptosis. He underwent a surgery. You can see a scar on the right upper eyelid, and a month after surgery, his ocular motility was all over. Because the myasthenia, ocular myasthenia gravis was missed, surgery was done, and the disease progressed, and his eye movement was really very awry. And unfortunately, patient ended up blaming his ocular motility on surgery. Of course, I mean, he doesn't know that it's not nothing related to surgery. So that's the importance of making sure that we don't miss out on a diagnosis of ocular myasthenia. So that was the first case scenario. We're talking about ptosis and diplopia. Ocular myasthenia gravis, variability, those funny lid signs, fatigability when you see the patient, eyes test. When in doubt, you can do pharmacological tests. However, some of these pharmacological agents are not very easy to lay a hand on. And antibody test. Now, presence of antibodies would help that this is ocular myasthenia gravis. However, absence of antibodies in a pure ocular form does not rule out ocular myasthenia gravis, because up to 40% or 50% of these patients may not have all antibodies. Now, so we change gears. This is a 40-year-old lady, diabetes, diplopia with ptosis, and you find there is a right ptosis. She was told that maybe your problem is related to diabetes. She was also told that you have a little cataract. She was telling that there's a little blurring, so that maybe you should undergo cataract surgery. You see what happens when you check ocular motility. When patient looks to the left and right, ocular motility seems to be okay. See what happens when the patient looks up. You will find that there is a limitation of elevation. And when the patient looks down, the depression is by and large okay. You see the right eye, there is a limitation of elevation. Anything else anybody noticed apart from ptosis and limitation of elevation? Any other? Yeah. You find that the pupil on that side is larger. There is anisocoria. So this is a patient who had partial third nerve palsy with involvement of pupil. This is a medical emergency. You are suspecting compressive lesion of the third nerve. Why it's an emergency? Because one of the commonest compressive lesion of the third nerve is aneurysm of posterior communicating artery. So this patient should undergo MRI with MRA. You want to rule out the aneurysm. There are other signs which can tell you that you are dealing with aneurysm, as happened in this patient. I'm sorry the video is not playing. Patient had third nerve palsy 6 weeks ago. No neuroimaging was done because the patient was told that maybe it's related to his really altered vasculopathic risk factors. However, when the patient recovered from the third nerve palsy, you found that when patient adducted, there was widening of palpebral fissure. When the patient looked down, there was a lid lag. These are the two signs of aberrant regeneration of third nerve. So apart from involvement of pupil, aberrant regeneration of third nerve also tells you that this is likely to be a compressive lesion. So, and these patients will require MRI with MRA. However, now there is a thinking that any third nerve palsy, irrespective of involvement of pupil or no involvement of pupil, should undergo MRI with MRA, because what you are likely to miss out is fatal. So that's about the third nerve palsy, and I'll give you some numbers, and that's the reason why the MRI is important, because 10% of these patients who develop third nerve palsy because of aneurysm, they can actually pass away before any medical attention is given to them, and 50% of them can die within first month, and the survivors are likely to have residual incapacitating neurological deficit. So that's about the third nerve palsy. This is an interesting patient, a 70-year-old gentleman who was a known case of Parkinsonism, and he was telling that I have some double vision and I also have ptosis. I have drooping of eyelid after I read. So initially we thought that maybe he has myasthenia, until we saw the patient and we recorded. And you see, it's a little long video, but you find that he's not really moving his eyes as briskly as he would like to. And there is a limitation of ocular motility, especially in the left eye. But his problem of closure of the eye, which he said, or he was told that, yeah, you have ptosis and diplopia, maybe myasthenia. See what happens, this is what used to happen. After he has read for some time, he would have closure of the eyelids, and then he has to really mechanically make sure that the eyelids open up, and that's what he did with the right upper eyelid, and you'll find that the left upper eyelid, after some flickering, would open up. So this is not really a ptosis, this was apraxia of lid opening, which is also can be a part of Parkinsonism, which sometimes can be confused with ptosis and diplopia. We have one more example of patient with ptosis and occasional diplopia. She is a lady who started having bilateral ptosis 3 years ago. She's a 21-year-old lady, and it was a progressive worsening of ptosis, which was near symmetrical. She had diplopia initially when she started having a problem, but after that there was no diplopia because the ocular motility was symmetrically affected. So this is an example of patient with CPEO. Chronic progressive external ophthalmoplegia can be isolated, it can be hereditary, or it can be a part of Kearns-Sayre syndrome, where patient can have associated heart block. A similar kind of limitation of ocular motility, which can occur in older male, is myotonic dystrophy, where patient again can have bilateral ptosis with progressive ophthalmoplegia and myotonia of lid closure. They can also have effect on the pupil. They also can have glaucoma. And I'll end with the last example of ptosis with diplopia. This is a gentleman who had a sudden onset complete ptosis. Initially there was a diplopia when the lid was drooping. After that there was no diplopia, obviously, because there was a complete ptosis. And you find here, when you check ocular motility in the right eye, there is hardly any movement on any side. So now when you have this kind of problem, when you have ptosis and limitation of ocular motility, you localize this lesion either to the orbit or cavernous sinus. Now a simple way to differentiate whether this problem is cavernous sinus or orbit is to look at the vision. If the optic nerve function is preserved, you are looking at cavernous sinus. If the optic nerve function is affected, you are looking at orbit. So that's about ptosis and diplopia. We looked at myasthenia, we looked at third nerve palsy, we looked at orbital or cavernous sinus lesion, and some of the rarer features like myasthenia and supraorbital palsy. I'll continue with my second talk. Yeah. So my second talk actually was supposed to be given by Dr. Celia Chan, but she couldn't make it. So I'm going to fill in for Dr. Celia, and I would like to acknowledge help from my mentor, our mentor, mine and Ambika's mentor, Dr. Naveen Jaykumar. I based my talk on his talk. So as Rohit was mentioning, any diplopia, the first question that you'll ask is diplopia monocular or binocular? If diplopia disappears when one of the eyes is closed, it's a binocular diplopia. You're looking at asymmetrical ocular motility. If the diplopia persists even if the eye is closed, you're looking at some ocular cause. Now, when we're talking about vertical diplopia, you need to ask for these three questions apart from that diplopia questionnaire. Were there any previous eye surgeries? Because sometimes an eye surgery with asymmetrical fibrosis can have a vertical diplopia. Was there any trauma to the head or the orbit? And associated CNS features. The first thing you look at when you have a patient with vertical diplopia is what is the head position. What is important for us for this talk is there any head tilt, and is there any chin up or chin down position? Because both of those would tell you that patient has a torsional diplopia with a compensation with a head tilt or a chin up and a chin down position. The motility examination would involve ductions, versions, and cover test. An additional test which will help you would be a Maddox rod test. Normally when you place a Maddox rod in front of one eye, you'll find, so if you place it vertically, it will create a horizontal line, and you'll find that the horizontal line is aligned with the dot. And whenever the eye is elevated, the image goes down. When the eye is depressed, the image goes up. So for example, if patient has right hypertropia, you place the Maddox rod in front of the right eye, you'll find the line which is produced by the Maddox rod is down. So that's number one. The other 2 points to remember, you are looking at the elevators and depressors. So when a patient, for example, in this example, when the patient is looking to the left eye is abducting, right eye is adducting. So what muscles are acting? When the patient is looking to the left, the abduction is brought about by superior rectus and inferior rectus, and the adduction, the superior oblique and inferior oblique are working. And another important point about the intorsion and extorsion, remember superiors are intorters. So keeping that in mind, let's look at a couple of examples of patient with vertical diplopia. Oh, I'm sorry. So I'll show you those example. The screen is gone. So I have basically two videos, one showing the superior oblique palsy, where I wanted to show you the three-step test, which will tell you how to do three-step test and how do we really come to a conclusion. So three-step test, the first thing is you notice, first thing to observe is which eye is higher. So which eye is hypertropic? The second step is what happens to the hypertropia when the patient looks to the right and to the left. And the third step is what happens to the patient. And third step is what happens to hypertropia when the patient tilts his head to the right and to the left. So let's take an example of right superior oblique palsy. Superior oblique is a depressor. So in a right superior oblique palsy, when the patient looks straight, the right eye would be higher. So there is a right hypertropia in most instances. Now the second step in a three-step test is what happens to this when the patient looks to the right and to the left. Right eye is higher. In a superior oblique palsy, when the patient looks to the left, the inferior oblique, which is acting, will take the eye higher, while superior oblique, which is supposed to negate the action of inferior oblique, is not working. So when the patient looks to the left, the hypertropia will increase. And third step is the head tilt. So when the patient tilts the head towards the right side itself, when you tilt the head to the right side, the left eye is supposed to extort, right eye is supposed to intort. Superiors are intorters, superior oblique is not intorting, so the eye will go up. So here is a patient who has a hypertropia which is more on the right side. If it's a superior oblique palsy, the hypertropia will increase when the patient looks to the left, and hypertropia will increase when the patient tilts the head to the same side.
I request the people who are standing behind to, there are some chairs in front also, you can join us.
स्टैंड मोड पे है
While we're
All right,
working
I
out,
think there is anyway, it doesn't matter. So these are the 3 steps that you follow when the patient has a hypertropia. So they which eye is higher, what happens when the patient looks to the right and left, and what happens when the patient tilts to the head to the one side or the other side. Now there is another feature which will help you to determine what's going on. And that is you look at the fundus. Now superior oblique, let's say we are taking an example of superior oblique palsy. Superior oblique is an intorter. If the superior oblique is not functioning, the eye would have gone into excycloversion. So when you look at the fundus, you'll find that the optic disc is higher and macula has gone down. So that's something which again will give you a clue as to what's going on. So that's one important cause of vertical diplopia, a fourth nerve palsy. The other cause, which Rohit partly mentioned, is a restrictive myopathy like thyroid ophthalmopathy, or a patient having, let's say, blowout fracture. So here is an image which tells you that this is a fundus examination of left superior oblique palsy, where you find that there is macula which is down than the optic nerve. So that's something which you can look at. What about bilateral fourth nerve palsy? Again, patient can have a vertical diplopia, but here there will be right hypertropia in the left gaze and left hypertropia which increases in the right gaze. Patient can have a small hyperdeviation primary gaze if there is an asymmetrical palsy. Patient would have a large excyclotropia with a V pattern esotropia. I'm sorry for the video. Now this is the second video was about left inferior rectus palsy. I had a video of performing the Belchowski's or Marshall-Park's 3-step test in patient with left inferior oblique palsy, where it would have behaved differently. So in a superior oblique palsy, you'll find that hypertropia is more when the higher eye is adducting. In this patient with the left inferior rectus palsy, because inferior rectus works when the eye is abducted, you would have found that the hypertropia was more when the higher eye was abducting. And this was a patient who had floor CT, and this is CT orbit, where you find there is a fracture orbital floor. So other cause, so that's about the superior oblique palsy or a blowout fracture. Other cause can be a supranuclear cause, which is not very common for us to see in an ophthalmic OPD, which is a skew deviation, where there is a vertical misalignment, which can be constant or transient, and patient can also have double vision. In patient with skew deviation, you will have hypertropia always present in primary position. However, the differentiator between a superior oblique palsy and a skew deviation is looking at the fundus. In skew deviation, the higher eye would be intorted, which is in contrast to superior oblique palsy, where the higher eye would be extorted. Apart from that, you will find that there is a binocular tilt of subjective visual vertical, while in a superior oblique palsy, there will be a monocular tilt. One of the tests which is often described in a skew deviation is you make the patient lie down in a supine position. You will find that the hypertropia decreases. Skew deviation is because of supranuclear problem. It can happen in somebody who has, let's say, a medulla problem. Now these are the other rare causes of vertical diplopia, like hemifield slide phenomena, which is often seen in somebody who has a chiasmal compression. In a chiasmal compression, you have a bitemporal hemianopia. So in other words, the retinal correspondence is lost. So any patient who had that mild phoria would become apparent, and that is called hemiphil's life phenomenon, where especially a vertical phoria gets manifest and patient complains of vertical diplopia. The other important features is foveal displacement syndrome, or very rarely a non-organic cause of vertical diplopia. So we covered ptosis and diplopia, where we spoke about myasthenia, and as I said, myasthenia would be in differential of any patient who has an acquired ptosis or even acquired diplopia. Patient can present with vertical diplopia in myasthenia or thyroid as well. Thank you. I'm sorry for the video.
We keep up the applause and for Rashmin having done his level best with adverse IT circumstances. And I think the important point that he was trying to make was that when you're doing the when you're doing the Bilchowski test, it is common to think of it as a test for a fourth nerve palsy. It is not a test for a fourth nerve palsy per se, but the test for to isolate the vertical cyclovertical muscle that's involved in a vertical diplopia. Do you want to take some questions now, Rashmin? Or
We'll do it later.
Okay, we'll do it later. All right. Okay. Then it gives me great pleasure to introduce our next speaker, one of the leaders in our field of neuro-ophthalmology, Dr. Ambika from the Shankara Nethralaya Institute in Chennai. Ambika, please.
Yeah, in fact, Dr. Manju is going to cover about it. She's a screen session. We'll take it at the last so that we make sure that all speakers have their say.
Good morning, everyone. Well, thank you, organizers, for this opportunity. Well, I'm going to do a talk on diplopia with vision loss. And I'm a neuro-ophthalmologist, so obviously no financial interest. So diplopia with vision loss don't go together. So if you see a patient with diplopia and he's going to walk in after a while that my diplopia is gone and I'm having a no diplopia, well, that's not a good sign. So that's something which you have to watch out in a short interval, a diplopia vanishing off in a patient. So I asked Rashmin, what should I cover? This is not a very comfortable topic. He said, just start exploring the no man's land, orbital apex. So this is my topic today. So what are the warning signs for these serious issues? It can harbor serious systemic diseases like joint cell arthritis, many orbital pathologies like thyroid eye disease with IIOID or myositis. My previous speakers have narrated few of them. Well, let me restrict to my talk to orbital apex. So although this is the anatomical landmark what we are going to discuss in this talk, orbital apex, superior orbital fissure, cavernous sinus syndrome, well, these are not miles apart. So any lesion which starts in one is easily going to slip into the other, and what you see in the radiological feature is something sitting across the orbital apex to the orbit to the cavernous sinus, something like this. So anytime a lesion, it might take even days to hours for a lesion from one segment to move on to the next. So you have to really be very fast in acting in such lesions. So orbital apex refers to the multiple cranial nerve palsies with or without optic neuropathy. So it can be also isolated at times with vision loss. And this is the classification what is being textbook described, where you have a superior orbital fissure involving 3, 4, V1 and 6, and that of an optic nerve dysfunction is the orbital apex, and that of a V2 with an oculosympathomimetic is the cavernous sinus syndrome. So these are the list of causes which I may not go into. These are the common ones which we encounter in our clinical practice, starting from inflammation to mass lesion to infection to vascular lesions and post-traumatic or unfortunately after few iatrogenic ENT surgeries. So how do you evaluate such a patient? Just like how you go about doing a diplopia evaluation, go for a detailed history taking, systemic illness, and watch for associated signs like proptosis, squint, ptosis, vision loss. All these are going to matter a lot, and do not forget to perform an optic nerve function test in such patients who are walking in even with diplopia of whatever type, horizontal, vertical or whatever. Do perform a complete optic nerve function test, because that's what is going to guide us, not missing this group of diseases. So there are some adjunct tests like OCT, but visual field is mandatory. And MRI brain and orbit is the preferred neuroimaging of choice, particularly thin cuts, fat suppressed, post contrast, If preferable, a 3 Tesla, but 1.52 will always do better, but with a flare and a stir sequences, and a fiesta probably in a cranial nerve palsy. And CT has a very limited role, maybe after post-traumatic fractures, meningiomas, or to decipher the bony details, particularly in diseases like pneumosinus dilatans or fibrous dysplasia. So this is the algorithm what we follow for the orbital apex. If you find, the first thing is go ahead, get an imaging simultaneously, and if there is a history of trauma or surgery, rule out an infection, because we are going to, next step is plan for a steroid therapy. And if there is a complete no possibility of infection, you can move on with steroids. And if it's a mass, it might be a space occupying primary lesion or a METS. And if it's a vascular, perform angio. And do not forget, giant cell arteritis can walk in with a headache and a diplopia, and sooner it might eventually pass on to an arthritic anterior ischemic optic neuropathy. Please do remember that. And as I said, steroids is the mainstay of treatment, but rule out an infection, and radiotherapy has its role in refractile cases. And if it's an infective association, do not, be very judicious on steroids. Just inch it by with an antibiotics, be it an antifungal. And in our group of patients, we have a lot of tuberculous patients coming up like this. So we may have to give an antituberculous cover also. I'm just going to go through a few cases, whatever is permissible in this time. So this is a 65-year-old male who is walking in with diabetes and hypertension history with 3 weeks onset left sixth nerve palsy. But after the diplopia, he suddenly developed a drop in vision for which he has come. And CT brain done elsewhere was normal. So his vision was 612 in the left eye, but when we repeated the imaging, he had a lesion in the cavernous sinus which was almost entering into the superior orbital fissure. So 3 weeks back diplopia turned into a vision loss by the time he came to us. And already there was a CT which was normal. So with a judicious use of steroids, he recovered. And this is a 23-year-old guy who had a history of headache with diplopia and ptosis following a zoster infection. You can see the scars on his forehead and the nose. He developed a sudden redness, and after which he developed a movement restriction and a vision loss, and we found a lesion in the cavernous sinus, and that guy responded well with antivirals. So as I said, TB is something which we have to watch out in our part of the world. So this guy, he had a previous history of a recurrent uveitis for which he had the vision loss. So his vision loss was because of a posterior uveitic entity, but he came with a left sixth nerve with a marginal lesion in the cavernous sinus. So with a watch, he recovered. He had already finished a course of tuberculous therapy. He was on steroids by the time we saw, and this is between 3 to 4 months. His lesion in the left cavernous sinus resolved, but he boomeranged again, coming with right third nerve. This was almost 6 months later, and pupil sparing right third nerve is what he came back, and this time the lesion was sitting in the right side cavernous sinus. So at that time we repeated all the TB investigations. Everything was positive. We didn't have a choice. We had to give her again a cover of ATT with a steroid, and that's when he settled down. And this is a guy who came with a sudden drop in vision with a frozen globe. He started with diplopia, but when I saw it was a frozen globe almost with a red and congested eye, and when we imaged, we had an extensive lesion sitting in the sinuses, nasal cavity, cavernous sinus, orbital apex, everywhere. And then he said that he had some ENT procedure for the maxilla, following which he has developed this. But unfortunately, there were a lot of lesions in the sinus cavity, which I requested the ENT person to go ahead and get an antral washing and a biopsy done, and it turned out to be aspergillus. So watch out in a poorly controlled diabetic, a fungal lesion. And there were era of fungal lesions even before COVID, because we all are smitten by the rhino-orbital mucar, but there are so much of fungal lesions even before that, because we have a high index of diabetic population in our country. And this is a 41-year-old female who was referred to me as a thyroid eye disease, and she had a history of squint and ptosis over a period of 2 years. And she had a previous imaging of CT orbits, which was normal, and her visual acuity in the right eye was 618 N8, and that of the left was normal, and she had a relative afferent defect in the right eye and a mild disc pallor in the right eye. So how many of you would agree that this is a thyroid eye disease? What do you see in this photograph? So it's a quiet eye, maybe there's a mild ptosis in the right eye. So what's happening here? There's adduction restriction, elevation restriction, and depression, but abduction is fine. But along with that, what do you see? What is obvious in this photograph and in this? Brilliant. So that's a sign of aberrant third nerve regeneration, which means the third nerve is going this compression for a longer period of time, and that is not a thyroid eye disease sign. So I asked her, you may have to go for a repeat imaging, and she had this also in addition. So one more clue. What do you see in this? Is this feels normal? Okay, this is definitely black and something bad. What is this? Partly black. So what do you think it is? Where is the level of lesion? Something is abnormal, isn't it? So you could see a superotemporal defect in the left eye, which is the 6-6 eye, and this is an advanced field loss with a dense temporal. So definitely this is not a normal condition or a thyroid. So unfortunately she had a CT orbit which was normal. If they would have just pushed the cuts up, they would have picked this lesion long back. And that is an MRI which showed a huge supracellular pituitary mass, and that's the reason why she had a multiple cranial nerve palsy with a vision loss, and that's post-tumor excision, her improvement of the visual fields. So this is a 10-year-old female who was referred to us with complaints. In fact, this patient was referred by an interventional neurologist who said that the patient has come back with a sudden drop in vision in the right eye for 10 days, and we just did a CCF management 2 months back. We had done an endovascular coiling for this kid. So this was the picture what he shared with me. It's a clinical acute subacute proptosis in the left eye where you could see, and she had recovered very well after the endovascular coiling. But now she has come back to us with a sudden drop in vision and a diplopia. And her vision in the left eye was 6/12, and fairly the disc was having only a subtle temporal pallor. And you could see that there's a complete EOM restriction in all direction in the left eye. When we repeated the imaging, we picked up that close to the vascularized coil, there was a saccular outpouching of the ICA. So there was a huge saccular aneurysm of the left ICA, and that has been compressing over, and this image MRA is confirming that it had a huge lesion which is extending into the superior orbital fissure, and that's the reason why she developed after 2 months of the treatment a sudden diplopia. And the interventional radiologists, they just opted because they wanted to wait for a while, go for a course of steroid, and then probably they will take up. But she responded well with a course of steroid therapy, but still she is under our follow-up. So this is the course of thing what went through. CCF managed well, recovered, but then subsequently she developed a thing. And as the previous speakers have already highlighted, oculomyasthenia gravis is a great mimicker. So it can happen in any form, so watch out for that. We also did a short case series of our group of people where we found that most of them were unilateral, inflammatory condition, infective, followed by metastasis and tumor. And yes, neoplasm also was high in younger individuals, and cavernous sinus lesion was filled mostly with neoplasm, and superior orbital fissure invariably had inflammatory lesions. And younger individuals had neoplasm, and middle to older group individuals had more of inflammatory etiologies. So to summarize, orbital apex syndrome can present with even an isolated cranial neuropathy, but watch for optic nerve function test because we can't miss it if it is going to be not assessed. So neoplasms are common in young individuals and inflammatory diseases in older age. They do respond well to treatment, and we need a multidisciplinary management for these conditions. Steroids can be used judiciously, but be careful in poor control diabetic, watch out for infections which are coexisting, and definitely an ophthalmologist plays a good role in these sort of diseases, and we need a multidisciplinary approach in controlling them and conquering this no man's land. Thank you so much.
Thank you so much, Dr. Ambika, for those lovely cases, which we expect from you now all the days. Next, it's an absolute honor to have Dr. Clement Tan, who has joined us from Singapore, and we thank him for always supporting the educational cause of AIOS and INOS. He's going to talk on diplopia with red eyes.
Good morning, and want to thank the organizers, EPO and AIOS, for kindly inviting me to be part of this course. And they gave me this enigmatic topic, diplopia and red eyes, and I asked, well, what do you want me to talk about? So I took the perspective of a resident and said, if I see a patient with diplopia and red eyes, if I don't want to wake up the neuro-ophthalmologist in the middle of the night, although they actually don't really care and they will wake us up anyway, what would a resident in the 21st century do? And I said, well, they probably ask Google, and Google now will go straight to Gemini, and the smarter ones will have got ChatGPT or Perplexity, so they would ask them. So I said, okay, why don't I ask one of these and say, well, what would they tell a resident at 2 a.m. in the morning? And they started off with this, that they said, well, the mechanisms linking red eye and diplopia will be orbital congestion, venous stasis, extraocular muscle dysfunction, congestion, cranial neuropathies, neurovascular compromise, but tells you nothing about where you're going to find the where you're going to actually find the lesion, right, of the patient. But we all do know that these are the common conditions that will give you diplopia and some red eye, right? Thyroid eye disease, you've heard it mentioned a couple of times this morning already, is pretty common. And they do have red eye. You heard a brief mention of carotid cavernous fistula, and we'll speak a bit more about that later. There's this entity called cavernous sinus thrombosis, which we all fear to see because it usually means the patient is very sick. Because briefly mention infections and inflammations at the orbital apex, but also don't forget this can happen in the orbit itself. And besides infections, you have a whole host of inflammatory conditions that can give rise to diplopia with a red eye, because if it's an inflammation, well, the eye is going to be red as well. So that will include things like idiopathic orbital inflammation, or what was once known as orbital pseudotumor, any inflammatory orbitopathy such as granulomatosis with polyangiitis, orbital myositis, and the flavor of the last couple of years, IgG4 disease. Thyroid eye disease, and you can see a really nice write-up on this on iWiki written by our very own Rashmin Gandhi. Rashmi, I attributed it correctly, right? Yeah, he's looking modest over there, right? But if you look at and we know that this comes with autoimmune thyroid disease, but 10% can be euthyroid or hypothyroid, and I put there in red, compressive optic neuropathy. Ambika mentioned it earlier. It's really important in looking at a patient with diplopia and red eye that you don't forget the vision, right? A whole host of tests to be done when you're suspecting thyroid eye disease. Imaging is very important to show the enlarged muscles with sparing of the tendons. And then treatment is with initially, now we have a good number of steroid protocols, high dose steroid protocols. Radiotherapy, I think, is still used fairly frequently. And then we have this new wonderful drug called teprotumumab, which most of us can't afford. And if you do have access to this, don't forget it can bring about hearing loss. Right? And finally, there's orbital decompression. But I really wanted you to have a look at this clinical activity score that you have over there. And you look at the number of things that say redness, right? It's 3, 4, 5, 6, and 7, all have to do with redness of the eye. So a little bit of a proptotic eye with a bit of lid retraction and redness almost should signal to us an active thyroid disease in many circumstances. And really, the limitation of eye movement in terms of the clinical activity score comes in on the follow-up visit. But you are going to see the patient at the first visit, and so this is something that we ought to suspect when we see a patient with red eye, a bit of proptosis, and double vision as well. Okay, this is a unilateral thyroid eye disease. You know that in terms of proptosis, bilateral and unilateral proptosis, thyroid eye disease is probably the first diagnosis you have to think about. You can kind of see that subtle redness, I don't know if it's visible there, on the conjunctiva. It's just very subtly red. Don't forget they also have dry eye, but they also have this redness over there. And so, look at the limitation of movements in a number of different directions. Okay, this is the unilateral proptosis with thyroid eye disease and the lid retraction. Now, you say, where's the lid retraction? Well, the inferior lid is retracted, right? And that's actually one of the signs that we sometimes miss, the inferior lid retraction. This is the more common one with superior and inferior lid retraction. And again, look at that. that redness, that diffuse redness of the eye. And this is how thyroid eye disease presents. Also notice that where the limitation of movement is primarily in up and out gaze in either eye, so telling you that there is limitation in the direction of the superior rectus, which then points to restriction of the inferior rectus. But you heard this earlier, right? A patient presenting with history of thyroid disease and then vision loss and poor limitation of eye movements. Once you see this, you should really start to think of whether the patient has got thyroid eye disease and quickly do an imaging and quickly attend to this patient so that they don't lose any more vision. But I wanted to quickly move on to this very busy table here, because I was thinking if I were a resident on call at night and I had a patient with this, well, how am I going to think through all these conditions? Because as you can see, they're all first of all, in terms of their presentation, they all come acutely or subacutely. They're all very similar in that they all have redness of the eyes of some sort, and they have limitation of eye movements. Inflammation and infection typically cause pain, right? Typically cause pain. But if you have a look at cavernous sinus thrombosis as the condition that might kill the patient, they're typically sick. They have a fever, they have chemosis, eyes proptose, doesn't move. They may have lost vision at that point. They may be septic, right? And then when you do the imaging, right? When you do the imaging, don't forget to image all the way back to the cavernous sinus so that you can see, and that they will have non-enhancing filling defects in the cavernous sinus. What about inflammation versus infection? Well, not always the easiest to tell, right? Not always the easiest to tell, but look at the history, right? And that's in the bottom row there. Look at the history. If they have a history of recent sinusitis or dental infection, and ask this in the history, think about a possibility of an infection. If they have a history of autoimmune disease, well, you can start thinking about autoimmune disease, and then the imaging will give you some clues. A dacryoadenitis typically found in the context of an inflammation. A mass may also signify that. But in an orbital infection, look at the sinuses as well to see if they are involved. Look at the subperiosteal layer for subperiosteal abscesses. Carotid cavernous fistula should be the one thing that everybody who's ever read a book on ophthalmology will say, corkscrew vessels. But how many of you have seen corkscrew vessels in an otherwise very quiet eye, and the only reason for that corkscrew vessel after you've imaged the patient and worked them up is just dry eye, right? That happens all the time, right? But corkscrew vessels, that's the one that's a dead giveaway. And it comes together on imaging with enlarged superior ophthalmic vein, and when you see the corkscrew vessels, don't forget to order the angiography as well, because that's how they're going to make the diagnosis, right? So some useful questions to ask your patient. Do you hear any funny noises in your ear? Is there any pain? Are you ill with fever, headache? And then look at the vision, look at the pupil, look for proptosis, and then of course look for ptosis as well. So a couple of examples. This shows the vessels on the conjunctiva look a little bit. Yes, there we go. So this is so not a very brilliant corkscrew, isn't it? But it is a corkscrew vessel, and so that is indeed a carotid cavernous fistula. How about this one? This guy is clearly lying down in bed, and you have to pry open one eye. Yeah, so he's thinking, okay, this is a really sick guy. He's got cavernous sinus thrombosis. How about this fellow? And so this is also a cavernous sinus thrombosis, but you can see the source of his infection is the nose, right? Yeah, right. There we go. And this one with one eye red, but the other eye not able to elevate. Possibly a thyroid eye disease on one side, right, which is unable to elevate, but maybe the dominant eye, and therefore the other eye is just down. Why angiography? Because the classification and then the subsequent management for carotid cavernous fistula is really just based on angiography. And I thought some interesting things that we could take away from here is actually the sixth nerve is probably the most common cranial neuropathy in this, but muscle enlargement is also possible, right? And so that may be a restrictive picture. but I'm quite sure we're all quite hesitant to go do a force suction test on a hot eye. The eye looks red, and you touch it, you know it's just going to make it redder, and everybody's going to be really unhappy. But sometimes you just have to do that force suction test, right? I also wanted to point out that besides the enlarged superior ophthalmic vein, sometimes you also see T2 hyperintensity of that superior ophthalmic vein, and that will give you a clue to this being a carotid cavernous fistula. I wanted to, as come to the end, to just briefly touch on IgG4 disease, because this, you know, it seems to rise to the top of all our suspicions, right? And you can see that in order of involvement, it's the lacrimal gland first, then the orbital fat, then the muscles, but they also might involve the trigeminal nerve, so don't forget test corneal sensation, lids, nasolacrimal duct, and the sclera. We like to do serum IgG4, but remember, it's not the diagnostic criteria for IgG4 disease. You actually need to get tissue showing IgG4, right? And if you can't get in the orbit, maybe the salivary glands will help, but it's also not quite the site of involvement, so it may be just coincidental. So histological diagnosis, histology showing the lymphoplasmacytic infiltrate, and immunohistochemistry, so ask for it, showing the IgG4 plasma cells. Now it's more likely bilateral than the typical idiopathic orbital inflammation. If you have bilateral inflammation, think IgG4 disease. And so, in summary, just a simple thought process for 3 a.m. in the morning when you have a patient who decided to come at that time for diplopia and a red eye. Are there typical features, right? I mean, you looked at those pictures and all of you made the diagnosis straight away. See, so you're all qualified to be the neuro-ophthalmologist. Don't call us at 3 in the morning, right? Some of the features are really obvious. Lid retraction is probably going to be a thyroid eye disease, right? If the patient is pretty sick, you're better off guessing and looking for a cavernous sinus thrombosis or something a bit more serious than that, right? Is it unilateral or bilateral? What does the redness look like? If you have a corkscrew vessel, well, carotid cavernous fistula. Is there proptosis? Some of them do and some of them don't have it. Is there a pattern that suggests a cranial neuropathy? Don't forget, we are ophthalmologists, so what's the vision like? What's the pupil function like? And look in the fundus for any signs of venous congestion that will point us in the way of something vascular. And with that, thank you very much for your attention.
Thank you, Professor Clement, and that was a wonderful talk. We will move on to the next talk. Is going to be given by Dr. Manjushri Bhatte. She's going to talk on few challenging cases with diplopia.
So thank you very much. And at the outset, I'd like to thank APAO, AIOC, and Dr. Rashmin Gandhi for giving me an opportunity to participate in this session. So from red eyes and red nose, we'll come to some white eyes and challenges. And I'm very fortunate to practice in Hyderabad because I have Rashmin Gandhi in my city. So I can just pass on the challenges to him. So let's go through some of the cases. We will start with thyroid because that is one challenging condition with diplopia, and then move on to trauma. So as Dr. Clementham said, I asked ChatGPT for a nice cartoon or an image of diplopia, and this is what they gave me. So I kept adding more and more words to make it more specific. But anyway, so this is diplopia according to ChatGPT. But let's go on to the first case. So this is a 56-year-old gentleman, Mr. CB. He is a patient of thyroid eye disease for over 4 years. He's in the chronic phase now, or the fibrotic phase. He presents, as we can see very clearly, with a very large angle esotropia. His eyes, his right eye is sort of fixed in that adducted and slightly hypotropic position. He has an esotropia which on Krimsky he just cannot fix. It measures about 80 prism diopters. He has an abduction of -5, elevation of -6, as you can see in these, and he's also a high myope. So many times when you see both high myopia and thyroid eye disease, we want to know what exactly is the pathology going on. Why is he having the diplopia? Is it the myopia that is causing the globe to be so large that is displacing the muscles, or is it really the thyroid that is actually acting and infiltrating on the muscles. We got an MRI done. I don't have these images, but they showed really large and enlarged medial inferior, pretty much all the muscles, but it was slightly asymmetric. So then he moved on to have surgery for the right eye. At that time, he didn't want any surgery for the left eye because he was kind of fixing with that left eye. He went a large medial rectus and inferior rectus recession. This is his photos. So he first presented in 2023. This was last year, 2024, around this time. And there was a significant improvement. The recession was kind of supramaximal for the medial rectus and inferior because we don't always do 8, but then I just didn't know how to get anywhere close to that 80. So he now had a esotropy of 45 and a small right hypotropia. The motility was somewhat better, but there is still that limitation of abduction that you can see in the right eye with the blue arrow. He was still bothered with his diplopia. In fact, now it was even worse because now his images were kind of a little bit there in that field of vision and really disturbing him. And he was fed up of patching, but then he did vanish for 12 months and came back again. And this is just last week that he came back, and then finally he agreed for further strabismus surgery after 12 months, and this time we went to the left eye. So if we see over here, he has a left on right, that is the left eye is slightly higher as compared to the right, or we call it as a right hypo, but we can always balance the surgery by doing a little bit on the left eye, dropping down that left eye by recessing the superior rectus, and also balancing by doing a bit of medial rectus recession on that left eye. Still, it would not correct 45 to 50. Okay, so I was pretty bold, and we don't always, but there are cases where we have done a resection of that lateral rectus. In this case, the lateral rectus was pretty thin, so I've done a small resection of the right lateral rectus. He seems pretty cosmetic, day 1, day 2, with a very small esotropia, which I hope would fuse with prism. So this was one challenge which kind of went on for years together. Similarly is this patient. So he had thyroid eye disease, and his, if you see his MRI, his muscles are like really, he's done a lot of workout kind of muscles, really big, massive muscles. That superior rectus is so much more massive even compared to the inferior rectus on that right side. So his eye was fixed up, like just pointing to the sky, the right eye. He was fixing with the left eye. He was totally unhappy with the way his cosmesis was. More so his wife, who used to keep coming to the clinic with him. And he had undergone an orbital decompression, but this is what he looked. And it was only on the right side. After the orbital decompression surgery, he refused the left eye decompression. He said, I don't want to undergo this surgery now, just go ahead with my strabismus. So I did, so this is just pointing to that super large muscle. So I told him that we do a staged procedure because he had refused the left orbital decompression. He underwent a supramaximal right superior rectus recession. I just put that muscle on a hang back, almost 13 millimeters back from the insertion. I just let it slide back into the orbit, and also coupled it with a right medial rectus recession. He's fairly cosmetic. However, he still has the diplopia. In fact, now he has even more bothersome diplopia, but then he sometimes suppresses the right eye, and we are still waiting for him to go ahead with the left orbital decompression and then do further strabismus surgery on that left eye. So from thyroid, we'll move on to trauma. With trauma, it can be quite diverse and quite challenging. This is a 28-year-old male patient. He fell off his bike in June of 2023. And he had his diplopia, which was more in down gaze. And when he looked down, he said that there is tilting of the images. So the tilting of the images was more on the dextro and levodepression. So when he looked down and right and down and left, and he used to work as a farmer in the fields. So every time he's looking down, trying to work with his crops, and he's getting this double vision, which was pretty bothersome. This was his eye position. So as you can see, all that double vision and the vertical deviation is more in the down gaze. In the dextro depression, he's got a right hypotropia, and the left, he's got a left. So he basically did fit the clinical picture of a bilateral superior oblique palsy with a torsional diplopia. You can see some underaction of that superior oblique on the, I don't know if this point of it help me. But you can see some underaction of that superior oblique muscle on the right and left side. And looking straight ahead, he was ortho. So, it was very challenging to do a surgery on a patient who's straight ahead orthotropic, but just has this double vision, which is kind of not just, it's something which he has to deal with all day because of his profession. This was an X-cyclotorsion, which was noted on the double Maddox rod, which was very significant, as you can see even on the fundus photos. And so my options were just try and convince him to, just patch one eye, keep doing your job. And then he didn't really like it. He came back. We can't really give him prisms in this cases of torsional diplopia. And then the two options for surgery was either to nasalize the inferior rectus muscle and or do a Harada-Ito procedure. And I opted for a Harada-Ito procedure where the anterior fibers of the superior oblique, which are the torsional fibers, are then separated and moved to the superior border of the lateral rectus muscle. And this is the anterior fibers over here, which I'm suturing up. So he was pretty good post-operatively on his 9-gaze measurements, and this is what he looked on his 9-gaze, where he's got a very small exophoria. So that kind of ended well, but it's not always that simple. His torsion was also, or rather easy. This torsion was also much better when we saw him post-operatively. And when I say it's not always easy, is this other gentleman who gives a history of intermittent vertical diplopia now. He's unsure of when it started. Like, he's in his early 60s, and he says he probably had a fall at the age of 5-6 years, and maybe that's when he started, but it's all really sitting very vague. He has a small abnormal head posture. He has a left hypertropia, which increases in right gaze and left head tilt, though I would assume there would be some spread of cometants. He also has an inferior oblique overaction of that left eye, and his double Maddox rod again measures about 15. So this goes more, just because of the way the double Maddox is, I would think it would go more in favor of a bilateral, but an asymmetric superior oblique palsy. And these are his 9-gaze measurements. Again, as you can see over here, there seems to be some underaction of that superior oblique muscle on the right and left gaze while looking down to the right and left. And this is his fundus appearance. He is still awaiting surgery, but so this is always a discussion about what we can do, how much we can improve, how much do they really want things to proceed, and then take a combined decision. So incidentally, this is his imaging, and you can see these really tiny superior oblique muscles over here in both eyes on the coronals. So I don't know if it's just a long-standing atrophy sitting there, or what exactly is the story, which I can just explore and come to maybe next year. So let's go on to one more. So this is also a trauma with diplopia. So this lady, as you can see, she's just got heavy makeup on all the time, because she tries to camouflage all the scars that she has on her face after the trauma. She has this strabismus, the double vision. She has a significant enophthalmos of the right eye, and she also complains of vertical and horizontal diplopia. She does have some limitation of abduction of that right eye and adduction of that right eye, and we've got a little video which, I don't know if I can play this video. Okay. So this was preoperatively. So when she tries to move her eyes, there is absolutely no elevation, so it looks pretty uncosmetic for her, and she's a young, conscious female. The degree of makeup that she has is just phenomenal, because she just doesn't like the way she looks. Anyway, so she went ahead with the horizontal muscles, which was slightly offset, a recessed resect of that right eye, and she is much better. She has prisms and glasses now, which kind of help more with her double vision. So this was just a small little study, or not small, rather, it was a large data study, but we basically looked at strabismus following orbital wall fractures and looked at the incidence of diplopia that we've noted. A lot of them present with horizontal diplopias. Vertical and torsional are much lesser, but definitely there. So fractures is one big reason why patients can have some kind of diplopia, which is not so easy to deal with. And coming to our lucky last lady, so this is a patient with disturbing diplopia. She's a 45-year-old female patient who had injury with, so she had a, I don't know how she managed to smash this wine glass, Not only was the wine gone, but also the injury of that glass pieces, it went straight to her eye. And then she had this double vision on looking up and down. And she came to me after quite a while, and she wanted a solution for her diplopia. Luckily, her eyes were good, her vision was good, but as you can see, those red arrows, these are pointing to those glass pieces which are sitting on the superior oblique and the superior rectus muscle of that right eye. The rest of the muscles, the globe, everything is intact. So when she looks up, she gets double vision. When she looks down, she gets double vision. And if we see her measurements over here, so as you can see, she cannot elevate that eye. It's like a little, it's like an acquired brown. She can't even depress that right eye adequately in adducted position. And if we look at her 9 gaze, so she's ortho, or that's little sweet spot in the center, but when she looks up, the left on right increases. She looks down, the right on left keeps on increasing, and then she has to always try and move her head to find that particular area. I somehow decided to manage her conservatively because there was no point chasing those glass pieces, getting them out and looking at whether the scarring is going to change things or not. So this is a case of something called as a canine tooth syndrome, and she was best managed conservatively, given prisms for reading, and counseled a lot. So in conclusion, dealing with diplopia is challenging. We need to individualize our approach and management and try and improve the diplopia in primary and reading positions. I thank you very much for your patient listening.
Thank you, Manju. I think we had a question from the audience as to how do you manage the superior oblique palsy, if you can just at the same time.
I told right at the beginning, we have Rashman Gandhi sitting here, he is
No,
in
I think I'm
Hyderabad.
sure they must be wanting to
So
know about-
basically, yes, thanks. So we need to first evaluate the superior oblique palsy. Is it an acute, is it chronic, and what is the cause? Because just knowing that it's a superior oblique palsy is not enough. Knowing the etiology is most important. Both whether it's a local or a neurological condition, whether it's congenital and acquired, because all of them will present kind of differently. But if you're looking at acquired superior oblique palsy who come with this kind of diplopia, after figuring out how is the diplopia, whether it is a vertical deviation which is acute, as in it's a left hypertropia, worse on right gaze, worse on left head tilt, so we know it's a left, then we need to find out which are the muscles you need to deal with. If it's a small angle, sometimes we can wait depending on the etiology, as I said, and treat conservatively, and depending on which muscle is overacting, then it's a surgical decision. But all in all, it takes a lot of detailed evaluation. But I would always give a lot of emphasis to knowing what is the etiology, whether a neuroimaging is required or not, because we don't want to miss anything which may be sinister in these cases.
Any role of prisms anytime do you use?
There is a role of prisms in such cases, especially if they're ischemic fourth nerves and they're going to kind of hopefully resolve over time. Then it can be used like a little crutch if patients don't want to cover one eye, and then just see over time if things are improving. It depends on the degree of deviation, but for that we first need to rule out that there's nothing else that we're missing.
Thank you.
Thank you.
Any other questions? Yeah, Rishi. Maybe you can come on still because it's going online.
Just a query about the double Maddox rod test. I mean, not all cases will have like right eye going up in left gaze and the left eye going up in right gaze in a bilateral superior oblique palsy. Is there any demarcation beyond which degrees it is a bilateral superior oblique palsy, or I mean, clear cases which are not clear?
So usually 8 to 10, more than 8 to 10 on a double Maddox rod would point towards a bilateral involvement.
Yeah, please.
That's a great question. So if things are improving slowly, we can wean off the prism. As I said, prism is sometimes like a crutch, and it may delay the improvement as compared to a monocular patching or letting the patient being able to try and fuse. But as long as a patient is comfortable, they can even go on for years together with prisms. It's not something or an indication which is interim or surgery is the only option. It's very patient-centric. So there are patients who may not want and they're happy. It's just a prism that could be just ground into the glasses and they may be comfortable. So you can just go on with it.
Recently, we had a child complaining of diplopia of like for the last 3 days. He had this complaint. And similar episodes were there earlier also during the last 3 years. And when I examined the child, he was like very clearly mentioning that he had appeared for his examination, and when he was trying to write on the answer paper, few of the letters, few of the words he was writing properly, and then the words were like different sizes. Some were like bigger, some got smaller because of this diplopia problem. And when I went through the clinical record, it was mentioned Miller-Fisher syndrome. I asked the detailed history also, whether there was history of areflexia or anything. He had some issues with like walking, but as such there was no areflexia or nothing like that was mentioned in the case sheet. Now when I have this patient complaining of diplopia, I did the diplopia charting. It was right gaze completely involved, double images, primary and left side slightly, but then the responses were varying. It's not very clear cut, I mean the way we chart the diplopia charting, we do the diplopia charting. So how should I approach the case? The earlier MRI which was done in this case, that was normal completely.
Right, so there'll be a lot of factors. First of all, this looks like acute on chronic diplopia or something which is kind of variable intermittent. We need to know a little more details about how is the vision, the refractive error. So as Rohit and Dr. Rashman have said initially, we have to rule out all these causes, whether it's really a diplopia or not in children, and whether it's their ability to, like if it's something comitant or if it's something related to more close work or near work. So in the context of Miller-Fisher also, I would involve a neurologist as well and see what was their previous scans or reports or what treatment they had. It's not just diplopia, which, you know, we
Pediatric
just...
neurologist, actually, they had this doubt on this diagnosis, Miller-Fisher syndrome, and that is the reason they referred it to ophthalmology
Sure, maybe
department.
Dr. Clement.
The extraocular movements were completely normal, everything. Like, I couldn't make out what could be the reason there, why this child, and the child was quite, I mean, good in studies, so there was no reason to, you know, question me also. It was very affirmative. This is where I can see double images, this is where. And right half of the case, it was like perfectly. Every time it is the same place, same way.
It's interesting you mentioned that. So first about Miller-Fisher, if the patient is already out of the acute phase, and all has been done, you're just waiting for the binocular diplopia either to get better, or if there's a permanent deficit at the end, then maybe that will need to be fixed. But in this case, the history sounds a little bit different. What is interesting in what you mentioned is that he says the images with one eye are bigger than the other eye.
Yes, he showed
is
me
is that with his glasses or without his glasses?
with his glasses. He was wearing glasses and the refraction.
So one of the things we may need to figure out first is why the images are different, because it sounds a bit more like there's some anisoconia going on here. And so that if there's a difference in the refractive error, a very observant child might notice that he cannot really fuse the images very well, and that may also be conditional upon the type of glasses that he's wearing. On the other hand, you might want to have then a look at the macula and see why, is there a reason why one eye has a larger image than the other. So I might head down that way. And then also in your charting, do the measurements in the different gaze directions to see if there really is a difference in the images, a difference in the measurements when he's looking.
The distance between two images.
Yes, that's not the difference, but what you measure on the prism cover test in the different positions of gaze. So that might be helpful, at least to just get a little closer to the answer. I'm not sure we'll have a direct answer for you straight away today, but that may be the direction to hit.
Yeah, we were like totally directionless now. At least we have something. Thank you so much.
And I think if the patient had a history of Miller-Fisher, how soon you have seen the patient after the acute management?
Ma'am, the last two episodes, like, it was kind of annual. The first 2 times he was given steroid, IV steroid he was given, and he recovered. This time when he had this complaint, it started 3 days ago, and on day 4 we saw him.
There was no associated headache or any other features?
No, ma'am. We had one ENT consultation also, like if we are missing something.
Yeah, because if we are just going in one fashion, recurrent episode, child having a diplopia, it is.
Not how generally Miller-Fisher would.
It doesn't behave. Miller-Fisher is usually a single event after a viral illness or something, and most of the times it responds well to the acute management. We give some time, and then we see most of these children or adults with a Miller-Fisher. We give a time after an IVIG or so. By 4 to 6 weeks, they do mostly well. They do respond.
Unless they go into Guillain-Barré, otherwise.
That's the difference.
if you're having recurrences far apart and that respond to steroids, I might think of myasthenia.
Exactly.
So something
But
else.
yeah, but something else. But maybe not be myasthenia, but I'd have a closer look at some of all those other
Ophthalmoplegic migraine or something.
yeah, ophthalmoplegic migraine. Have a look at the orbits as well,
Yep.
and see what's going on there. If it responds to steroids, something is happening as well. So you've got two good clues there. One is the NIC cornea, and the other is the response to steroids.
Steroids.
Yeah, an episodic character.
Thank you so much.
I actually had a question for for Manju. When you are fixing a torsional diplopia, now it's always very difficult to even measure torsional diplopia except on the double Maddox rods. But how do you estimate how much to put the muscle to fix the torsion?
So, yeah, I mean, this is it's a very difficult question to answer.
Sorry.
But when I'm doing a surgery for torsional, especially in these cases of superior oblique palsy, many a times taking a decision to do a Harada-Ito itself, I need to think that am I going to be able to really help this patient or not? And often I feel that nasalizing the inferior rectus is easier because then you can just put it back if it hasn't helped the patient. But Harada-Ito, somehow it just works. And I've done a few of these and I somehow like that surgery. It's kind of become my preferred surgery. It just works. It just improves that torsion to a huge degree. Not always it will be perfectly set, but it does improve it to a lot degree. And sometimes the way the trauma is that they sometimes have to live with some degree of torsion, and we can at the most improve things but not fix it.
Yeah, if anybody, Rishi or anybody has any comment on that?
Most of the strabismus surgeries we have, clear-cut rules or algorithms. When this much amount of degree will, but when it comes to Harada-Ito, I think there is no way that if you fix the superior rectus this much away from the inferior lateral rectus, will get this much amount of torsion. But it does work. Always, I mean, most of the time it does work.
I just have one question to Professor Clement. And have you ever come across where you have clinically suspected a low flow CCF and the imaging is negative?
Yeah, sometimes the problem is you get both superior ophthalmic veins looking a little bit big, and then they're reported as normal. Or if you think they're big and you ask a radiologist and say, oh, that's within the limits of normal. But if your clinical suspicion is high, just do the angiogram and maybe even go for a catheter angiogram, because I think one of the earliest patients that I managed with this really was only on the catheter angiogram that we finally found the low flow CCF. So sometimes you're absolutely right. Sometimes got to think a bit harder. Are there any other questions from the floor? I thought maybe Rashmin, last one for you, because these days we are hearing a lot more about sagging eye and heavy eye. A lot more myopic people, a lot more older people. Goseki is over there. He might have a comment on this later also. When do you, in a patient with a vertical diplopia, small heights usually, start to suspect that this is heavy eye or sagging eye? Maybe Manju or Rashmin.
Yeah, I think you start suspecting when it's not fitting into anything which would cause that vertical diplopia. There is no apparent ocular misalignment. There is no, I mean, in all cases, the eyes seem to be behaving well. But yeah.
Yeah, I mean, I agree with what, and the motility will give us a clue. There will be, so if there is a heavy eye, that means that eye is so big that the muscles are being displaced, because that eye has to grow somewhere, and the easiest part for that eye to grow is the superotemporal area. So it's going to displace the superior rectus nasally and the lateral rectus downwards. So in that case, there will be some limitation of abduction. The eye cannot abduct completely, and the adduction in that regard will be full. The axial length would usually be anywhere more than 29 or so. And when we do a coronal imaging, we see an obtuse angle between the two muscles. So that all these things are kind of all together pointing to a heavy eye syndrome. And it's just realigning that muscle to its, normal cone so that it doesn't keep growing and pushing things.
So
So I usually check the MRI scan if distinguish the sagging eye and the heavy eye. So I usually check the superior and the lateral rexus angle, and if angle is the more than 100 to 20, and the heavy eye, the issue is the stronger, and then so this is a good point to. This point is important to the surgery procedure. So if the angle is bigger, the superior and lateral angle is bigger, and I do the Yokoyama procedure, and but the angle is smaller, less than the 100 to 20, and I do the conventional strabismus surgery.
Yeah, totally. I absolutely agree.
If there are no further questions, then thank you so much, and thank you, my fellow faculty, for that lovely presentation. Thank you.